Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I am Laura Carfing, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends, and welcome back to another episode of Breast Cancer Conversations. I love starting my week off with you guys. As you know, our podcast drop every Monday on Breast Cancer Conversations, so thank you, as always, for tuning in. When it comes to palliative care, cancer patients and their families often initially think of end of life. However, Dr. Janet Abrahm, professor of medicine at Harvard Medical School and pioneering palliative care physician, is reshaping this perception. Dr. Abrahm advocates that palliative care should not be seen as merely an end-of-life care, but it is an essential form of supportive care. When integrated early and delivered effectively, palliative care can significantly enhance patient outcomes and quality of life. Dr. Abrahm is a leading expert in the palliative care needs of cancer patients. With over 20 years of experience at the forefront of palliative care at Dana-Farber Cancer Institute, she is also the author of The Comprehensive Guide to Supportive and Palliative Care for Patients with Cancer, now in its 4th edition and a go-to resource for busy oncology and palliative care clinicians. Additionally, the American Society of Clinical Oncology, also known as ASCO, recently honored Dr. Abrahm with the Walther Cancer Foundation Supportive Oncology Award, the Society's highest honor. It is such a privilege to be able to interview Dr. Abrahm today. Welcome to the conversation. I am so excited because we're going to dive into such an important topic of supportive care, palliative care, what it means and how it can help with quality of life, pain management, and everything that comes after a cancer diagnosis. So Dr. Abrahm, thank you for joining us today. Please feel free. Can you introduce yourself? Tell us a little bit about your background and the work that you do.
So I started out in hematology and oncology. I was at the University of Pennsylvania at the time, and I did that for about 20 years. What I discovered during that time was that, if you will, symptom management, what we now call supportive care or palliative care, that's part of it anyway, could be life-saving. There were patients who could not have made it through the treatments without really sophisticated medicines to prevent nausea and vomiting. There are other people who were in too much pain to even think about a treatment. And so I became very fascinated with becoming as expert in symptom management as I could possibly be. I was recruited to come to Dana-Farber by Dr. Susan Bloch, who's a psychiatrist and palliative care pioneer, because Dana-Farber in 2001 wanted to start a palliative care program for its patients. As you know, a lot of people enter phase 1 trials, do all kinds of things, and they just wanted to be sure that all their cancer patients had the best possible palliative care and supportive care from their diagnosis on. So that's what we did. I learned a lot about psychological care, spiritual care. I learned a lot about best ways to communicate in the 20 years since I've been at Dana-Farber. So I feel that all the things that palliative and supportive care can offer, starting maybe with symptom management, but certainly when people have lots of forks in the road of what's the burden of this treatment? What's the benefit of this treatment? Where am I hoping to go? What am I worried about? That's when a palliative care clinician will partner with the oncologist to answer those kinds of questions.
How would a patient advocate for themselves to know that supportive care and palliative care is even an option for them? Is this typically offered through their oncology team, or is this something that you could ask for? Yes.
Mm-hmm. I would say that you could look on the website of any cancer center and see if they have a palliative care or a supportive care department or division. Usually it's a division, is what it's called, of the Department of Oncology. So what I'd recommend is to ask the oncology team, would you refer me to your palliative care colleagues? Because I have some things I'd like to talk about with them, about my symptoms, about the family, about things that you and I don't talk about in our oncology appointments, but that affect my ability to be the best possible patient. We're not social workers, though we have social workers on our teams. And most cancer centers have social workers. But we more focus on the goals of the treatment and the symptom management aspects, not so much helping your family cope with your illness. So we certainly would, with our social work colleagues together, help your family cope. We are board certified doctors, board certified nurse practitioners. We have pharmacists who are specialists in symptom management, and we partner with the spiritual care people at your cancer center and the social workers at your cancer center. So it's a real multidisciplinary team.
That's fantastic. I always tell people, like, the more people looking at my case and helping me and the doctors and the phone numbers I can put in my back pocket, the better, right? And so it really is a team approach. Now, when we're talking about palliative care and supportive care, and I don't know if things have changed since my own understanding of this, is it typically something offered only to people living with a terminal illness, or are early stage cancer patients eligible for this service, or does it depend on the clinic?
It probably depends on the program. At Dana-Farber, since I started the program in 2001 and I was an oncologist and hematologist, our mandate was from diagnosis on. For any stage cancer, it's a crisis. And if you are presenting with a problem, even though you think you'll be cured, you hope to be cured, we're there for you. Certainly with lymphomas, leukemias, germ cell tumors, they often can have very painful presentations, very painful. And so we're there to help you through the treatment complications as well as your presentation. And we hope to help you tolerate the treatment so you can be cured.
Yes, that's so great and reassuring to hear that, it's available to from diagnosis onwards. And, I think even reading in some of like the literature too, we're noticing like how do we keep people on these life-saving treatments and adhere to the treatment regimen, knowing that, pain management, symptom management can be quite debilitating. And when you're confronted with like, am I tied to the bathroom because I can't leave because I grade 3 diarrhea and I can't pick up my kids from school? I can't go grocery shopping. It's really impacting my day-to-day life. Um, how do we like you have those pros and cons. Like, should I continue? Should I stop? Is there another opportunity? So how would you, if you could just give me like a day in the life, like in that situation, and I'm just using the example of like a mom with kids who's going through very harsh treatments, what type of supportive care would you talk to the patient about, and what symptom management techniques would be incorporated?
There would be a lot. I think that we hope that she could bring her partner, if at all possible, or any family members or any supportive friends that would be there who are in her life supporting her. We would do an exploration of what her life was like before the cancer, what she was doing then, what she has lost in a way in terms of the right now. What can't she do that she would love to do? We would ask very detailed about her pain, her any nausea, any vomiting, the diarrhea, as you mentioned, strength, fatigue, all kinds of things like that. How her mood is, how her sleeping is, a very holistic assessment of who she is and who she was before and who she hopes to be again. And then we would apply specific medications. First, we would stop the medications that might be contributing. We'd advise her about diet. For example, when you're having diarrhea, milk products are a real problem. Your body really can't metabolize those very well. Then we would talk about what would be acceptable to her, and we'd use medications that would work with her main treatment regimen. So we talk with her oncologist, find out if more of the slowing medicines of the gut could work, like ondansetron, those medicines, whether fiber would be okay for her to take more fiber to bulk up the stool, whether Lomotil, Imodium, those things for diarrhea. And I'd urge her to tell her doctor that she has this much diarrhea because it could be life-threatening. So you want the doctor to decide, and it doesn't mean you're going to go off therapy. It means you're going to get some hydration, and maybe the next time there's a different combination of drugs that leads to less diarrhea. There's certain people whose genetic profile induces them to have more diarrhea with certain drugs. Your doctor might check your genetic profile and see if you're one of those people, if they haven't done it already, which they might not have, because most people don't have this problem. But if you do have a severe problem, don't ignore it and don't think you won't get any more treatment. You will get treatment, but you got to live through the next couple of weeks to get it. You don't want something terrible to happen because you're trying to tough it out. So it's very important to let your oncology team know, let them deal with it, and then they'll discuss with you what your other treatment options are.
That's great advice, especially, I think a lot of times as cancer patients, I know when I was going through active treatment, they gave me like this sheet of paper with all of the side effects. And you're like, okay, so I'm at home with my husband and I'm like, so this is normal, right? I'm supposed to feel this way because that's what the piece of paper said. However, if I don't tell my doctor, like what degree is actually normal and what is tolerable. And so I think that's really important to let them know all of those symptoms. And then the medical professionals then can assess like, okay, that's to be expected, but how can we make this better? Are you like able, how is this interfering with your day? And, can you get through it the next couple of weeks or do we have to like dose reduce or find another alternative? So I think
Or
that's
if you've
great.
been on antibiotics, you might have a bowel infection. There's a lot of variables that you're not expected to sort through. We just want you to talk to us. And often what you'll do is talk to the nurse practitioner, right? Or talk to the nurse in the office. Do that. Talk to the practice manager. Say, I have a really important soccer game and this isn't working. I'm not going to be able to go to my daughter's soccer game today. Does the doctor have any appointments available or does the nurse have any appointments available? Can I get somebody on the phone? That person will get you somebody and will let you know whether you need to come to the office or you can start with a virtual appointment. And then based on what the assessment is, you might need to come to the office.
And I love this idea of like talking with the patient and doing this like holistic assessment of them when they meet with you and your team. And I think it's so important to understand like what are the goals of the patient? Is it to reduce the pain? Is it to spend more time with their kids? Is it to continue to work through treatment? And really understanding what those goals are and knowing that they're going to be different from person to person, but to really map out and tailor the supportive care appropriately.
I agree completely. And I think that we also map out the worries because very often they're unfounded. There are lots of misconceptions about the different treatments. The worries are unique and the worries compound our ability to help a person. So if there's a worry about addiction, if there's a worry about the drugs that we recommend, if they've had other family members experience side effects from those drugs, it's just very important to talk about it. Or if they're worried that if they take the pain medicine now, there won't be any when the pain gets really bad.
Yes.
If
Oh,
you don't
so
find
true.
that out, if you don't find that out, you can't assuage it. You can't say, we've got plenty more where that comes from.
I was horrified of pain after breast surgery, like leading up to the surgery. And like I am very squeamish. The idea of having these drains coming out of my body, having to look at the blood to milk the drains, like I was like, it would bring me to tears just thinking about it. And so, really being able to communicate with my team to say, like, pain is a big deal for me. I am very scared. I am very nervous. We need to get ahead of it. How do we manage it? And ultimately, like, obviously I survived, like, everything is okay. I'm here to talk about it. But, I think, um, having those conversations and letting people know, like, what is my most biggest fear right now heading into the operating room and what is recovery going to look like? And so and I was, and I share this openly too on the podcast. Like I was a strict vegan before my diagnosis and was just focused on like health and wellness. And that was like, you're asking like, what was life beforehand? And, very active. And so to go through a cancer diagnosis where you are fatigued, you can't work out the way you used to, you were tired, your body is out of whack because all of the steroids that you're on. I was like hungry and craving carbs. Like everything was like so funny. I am no longer a vegan, but, for other reasons. And, um, this idea of needing to take medicine and to take pain meds and all of these other, like, supplements aren't the right word, but, like, all these other drugs to kind of help with, like, the nausea and all of the symptoms that come with chemotherapy and surgery. I share with people, I'm like, it's okay. Like I used to be like, no, I don't take medicine. And now I'm like, oh, please take it because it is so helpful to get through what we're confronted with. And so to me, that was a big mental shift. And I'm glad I was able to kind of get to that other side with the support of my medical team because, I needed it.
You must be a great coach for people. That must be really, really valuable to hear your experience.
Well, it's the combination, right? Of like the personal lived experience and then your expertise as well in the medical field. And so really getting information out there and letting people know, like, you know, it's okay to be scared and to recognize and honor the feelings and emotions that people have, but then also to provide them with resources and then they can make that decision. Is this the right path for them?
That makes perfect sense. And I think another thing women have, especially young women, especially someone like you who was vegan and took such good care of herself, there's so many why questions.
Gosh, yes.
When you get cancer, sometimes you're even kind of angry at your body in a way that you took such good care of her. And now what is this all about? Now, palliative care people can talk to you about that too. Those existential questions, those why questions, those places where the person you are, it shakes you a little bit to the very core of the person you are, and you question so many things. And so having a palliative care clinician share those concerns with you is really, really helpful because usually the oncologist is focused is a little different. And your time with the oncologist, you want to be spent a different way.
Exactly.
And to really get the most out of treatment, psychologically and spiritually, you need to be in the best possible place as well as physically.
Yeah, can we talk a little bit about that, like the psychological and the
Sure.
spiritual piece? Because you're absolutely right, especially for so many of us. I remember when I was diagnosed, everyone immediately asked, was there a genetic disposition? They wanted to know the reason, like why this happened to me. And, that in the breast cancer realm, that's between 10 and 15% of a diagnosis, right? Has this genetic predisposition. So I'm like, well, what about like the 80 to 75% of us? Like, why has this happened?
Yes.
And, you're absolutely right. This idea of, my body has failed me. How do I have this relationship with my body? We're trying to heal and, kill this devastating disease by again putting very toxic chemicals into our body. And so it's very juxtaposition, I would say, in terms of wanting to keep moving forward and then even bringing yourself to the oncology clinic week after week or every couple of weeks for treatment is like it weighs on you. You're like, I'm literally checking myself in to give myself, in my case, I had, I think adriamycin and a couple of other like tough drugs that now 8 years out, I'm now dealing with potential heart conditions, right? Because there's the long-term side effects, but at the same time, it's like, well, we got to live first. And then now we understand that there's long-term side effects that people are living longer, which is fantastic. But now how do we manage like survivorship and everything else that comes with it? I call it like the whack-a-mole syndrome, where it's like, okay, cancer is in check, but everything else keeps bubbling up. But the psychological piece, I think, is really important. And so, how do you help patients mentally with such a traumatic diagnosis?
Well, it does depend on if they had a psychiatric diagnosis before. So if they had an anxiety disorder, depressive disorder, or bipolar, we try very hard to get them hooked into our psychosocial oncology group. So we have psychiatrists who specialize in the care of patients with cancer and the concerns of patients with cancer. We also talk to them about, as I was saying before, forgiving them their bodies. A lot of forgiveness and a lot of frank understanding that it's nothing they did that brought this on. Questioning can be very revealing. Sometimes people feel that something they did brought it on. So a patient I had with prostate cancer asked me if it was the smoking that did it. And I said, no, is there anything else? Well, it turns out he had several affairs. So he was blaming himself because he had a cancer in that area. So there's a lot of guilt that can be associated with a cancer diagnosis, and people are searching for the whys. And then sometimes they're also feeling a little mad at God if they were faithful, if they were adherent to the sacraments or the rituals of whatever their religion or faith or spiritual practice was, they can sometimes feel a little lost when they have a cancer diagnosis, even betrayed. So we encourage them to go back to their spiritual teachers and healers. We let them know that they can heal and that usually, depending on the faith tradition, we can help, but the actual leaders of that faith tradition have a little more weight with the patient. So if it's a priest or if it's a pastor, especially if they're hidden angers at God, that that separation can be incredibly painful and nothing that any of my drugs are going to fix. So we do try to listen for why me questions and then try to unpack them, if you will. That's what we do a lot in palliative care is unpack the first layer of the question to see if we can find something that is maybe not even in the forefront of the person's mind. But as you unpack it, they make a connection that you would never have been able to make. Now, this is not psychotherapy. I do not do psychotherapy. But if I think someone would benefit from it, I refer to a social worker or psychologist or physician who does that kind of work, or if they need medication. We can kind of do Psych 101 for anxiety or depression. I would not mess with anybody's meds who have bipolar disorder. But we try really hard to at least get a sense of, is there a spiritual question? Is there an emotional question? And then pursue that with the patient and partner if we're allowed to.
Yeah, and to draw upon my experience with that as well, because I think a lot of times, and what I'm hearing you saying is like, from diagnosis on, there's all of these support resources. And I was never seeing like a social worker, psychologist, or psychiatrist prior to my diagnosis because it just wasn't something I needed support through. And so when it was offered to me as part of my diagnosis, I kind of, I don't know, kind of checked it out a little bit. I was like, no, I can come to chemo. I just need to get through like these appointments and I'll just muscle through. And it wasn't until probably a year later when I was transitioning after MFLA and going back to work and my hair was growing back that society basically was like, oh, you look healthy, you look fine. And I'm like, no, I'm still on maintenance drugs. There's still pills I have to take every single day for the next 10 years. Like there's still all of this stuff that you don't see, like the invisible illness of a diagnosis. And that's when I was able to like come to terms and admit that I needed additional support and talk to my team about seeing somebody. And so just giving people permission that, these things can bubble up, months later, years later, and it kind of ebbs and flows a lot like grief does, where, you could feel fine and healthy one day and then, for no reason, you're just like, oh my God, like it hit me today. Or, someone says something and it's triggering. And so
Triggering, exactly. That's good insight in your part, and I think you were a survivor in a way, and you relaxed enough when you made it through. It's very common when people stop active therapy for them to become incredibly anxious and depressed because they had the cushion and the system of the therapy, and now it's like, what do I do now? Do I wait for it to come back? What do I do? And where's that whole team that was there for me all the time? I see them once a month now. What is that about? So I'm really glad that you paid attention to your feelings and realized that you needed some help with that.
yeah, we hear that so much in our survivingbreastcancer.org community, right? It's like when they tell me to come back in a month or 3 months or 6 months, and I'm like, it should be like, you should be happy. Or I remember a woman sharing her story after radiation and ringing the bell, and she was done after like 30 days of consecutive radiation therapy. And she was like, but I feel this like loss. Like, she connected because you're seeing these people Monday through Friday. Like you get to know your team, and then to be like, okay, we're done now. And she's like, I should be happy, but I feel very like down, and just acknowledging that sense of loss and who's watching over me now.
Yeah, I think it's very scary. It's like the Raiders of the Lost Ark. You have to step out. The bridge will be there, but it's pretty scary to take that step. And I think there's so many women who get adjuvant therapy or effective breast cancer therapy who either they don't have that resource there or they think they should be fine now.
Right.
And it's way too soon to be fine.
So how, on average, like, do you stay with the patient throughout their treatment, or are you also like a resource to refer them to other social workers, or like, what's your relationship and how long and what does that duration look like usually?
Mhm. So we have a large department now, which is great. And when someone is seen by our outpatient group, they would continue to follow them probably less frequently. It depends on what the symptom is. If they have there are a lot of symptoms that continue when you're done with your therapy. There might be pain that comes after you have either a biopsy or a port put in, or the scar of, there may be post mastectomy pain or post port pain, post biopsy pain. Our therapy people usually refer somebody to the community, though, because we don't have enough therapists to treat people who are not under active therapy. So our psychiatrists and social workers will refer those patients to resources in the community. Normally, the patient, if they're not symptomatic, will not want an extra visit with us. They'll say, okay, I'm fine, and you're there if I need you, but right now I have no symptoms, and so I'd rather just not come back to this place any more than I have to. But we're available to see them when they see their oncologist. We're consultants to the oncologist. We don't have any patients on our own, if that helps. And I wonder, do we need to distinguish hospice care from palliative care? Is that something your audience already knows?
Let's talk about that because, I do think sometimes palliative care, when you say palliative care, they immediately think like end of life, I'm dying. Oh my gosh, like, why do I need to see these people? Right. And so,
Exactly.
that's, I think, a very like older term and way of how the practice perhaps may have been. But today, to your point, it's, alongside your treatment and to really be a partner of symptom management and quality of life.
Exactly. And hospice care started before palliative care. It started in the 60s in England and the 80s here. It became very active, where Medicare first created a hospice benefit in the 80s. Community-based care started in the mid 60s, was the first one in Brantford in Connecticut, because nurses wanted to take death back, if you will. They wanted to demedicalize the end of life. And so nurses started hospice programs based on the programs in England from Cicely Saunders. And they would have a doctor there to write prescriptions, but mostly it was a home nursing service that then Medicare started to pay for. And the rules from Medicare have flopped over to now, which is that if you want to enroll in hospice, your prognosis needs to be 6 months or less if the disease takes its usual course.
Okay.
And in general, you need to want to focus on a non-medicalization of that time, if you will. You want to focus on your family, being at home, your comfort, not coming back and forth to the hospital, having lab tests for treatment. But palliative care arose in the late 90s, and we first became a specialty in 2006 because academics like me wanted to help people who had life-limiting illnesses, be they cancer, heart disease, kidney disease, lung disease. We didn't want people to suffer if we could help them while they were getting active treatment. So we have the same philosophy as hospice, the holistic philosophy I mentioned before. But we can see anybody who has, for cancer, as I said, for us, it's from diagnosis on. And then in the other diseases, it tends to be the last few years of life with dementia or any of those other issues. And then if somebody wants to focus solely on being at home and their comfort, then we ask them to transition to a home-based hospice service.
I'm really glad you're bringing up the 6-month window as well. And we, there's a woman on our board living with metastatic disease. She's helped spearhead a lot of our programs for metastatic breast cancer. And so we've talked to, palliative care, hospice care, and even like death doulas to help us really understand about death and like demystify it, make it less scary, and talk about how, and I'll never forget this conversation we had with this woman and who was like, it is such a beautiful and intimate part of life. And she was talking about watching her husband pass and holding his hand and being there in like the last moments of his life. I still get goosebumps, but like the way and the beauty and the poetry of her experience to get to that point was like it was like such a close, beautiful, like intimate time for them. And I just thought that was like I've never heard of it that way. Like I always think like, I mean, it's very incredibly sad, but at the same time, being able to experience life because it's inevitable and death is inevitable, but it's something we never talk about. Especially like in my family, we don't even talk about it. Like
Oh,
it,
interesting.
it's
Oh,
I try to bring it up because of the work that I do.
yeah,
And
yeah.
unfortunately, like in our community, we do see a lot of people pass away from cancer. So I'm more accepting of it. But I remember um well, knock on wood, luckily, I haven't had a lot of people close to me pass away, but this past year I had a very close relative pass away. And I just remember like flying down actually in Pennsylvania, and being at the hospital with my uncle and just like holding his hand and playing music that he liked and, going through photos and just reminiscing and having that like bedside manner. And my parents were like, how do you know how to do this? And I'm like, because of
Yeah,
all the conversations. And, is it
yeah.
what's important to you? Is it having that like favorite Afghan or quilt that someone made for you? Or is there like music that would be calming or an aroma that like reminds you of like, Aunt Minnie's like chocolate chip cookies or something like that, right? And so,
Yeah,
I think that's, it's hard, but I think the more that we can talk about it and prepare for it, then you can be more present in that moment. And I think that's part of it too, where you don't want to be scrambling in like someone just passing and you're like, "Oh gosh, now I have all this paperwork to do," and like, passwords, like how can we prepare for the inevitable?
exactly. And I think that that's why the outpatient group, especially if they're taking care of someone with advanced disease, especially who's on treatment,
Mhm.
will push a little bit around the hopes and worries and fears, questions, and priorities. So that as the disease becomes more advanced while they're on treatment, everybody, including the oncology team, has a better sense. And there's more time to get, as you said, relatives together. We often will help the patient inform the ones that are the hardest to inform of the hard news. And we have special social workers and other people who help parents who have young children. So we have a special program for parents with young children. How do you talk to them? What do they need from you? We have lots of different social work and psychology and psychiatry, and we try to figure out what is it that's important to you and how can we help you get there. Sometimes it's material resources, like they don't want to die at home. So what are the options? Where could they die? What does their insurance cover? Sometimes it's getting someone who's in the armed services home because the Red Cross will bring people home. There are lots of other little things that we can. With me, I always make sure people have a baby monitor so
Oh,
that, yeah, so that the person, like your uncle who's in the bed, let's say that he was in
yeah.
a big house or something, that way there could be a couple of receivers so that if he needed some water or if he wanted something to eat or if he just wanted
Mhm.
company, he would just say that into the baby monitor and somebody could come and
So
help him
smart.
instead of
Things that, like, we don't think
ringing a
about.
bell or something, it's yeah.
Yeah,
So we
yeah.
try to be very practical about how to make this time as rewarding as necessary and try to be sure also that if there are religious ceremonies or sacraments that need to be done, to get them done in a timely fashion. But we marry people in the hospital. We get high school principals to come and give the graduation service early. There's Our social workers are infinitely creative, and if that's what you need, we'll do our very best to get that to you.
Amazing. You bring up this point too of, the wishes of the person who is passing or living with a terminal disease and during hospice care. But then there's always those relatives, or maybe it's a parent or somebody who's like resistant to those wishes of the patient and having to navigate some of those difficult conversations of, you know, but can we try one more thing? Is there one more clinical trial we could do? Is there something else? Right. And I think that's to be expected because everyone wants to hold on to hope and it's very hard to acknowledge the reality, right? And so I think you bring up a good point of like we're here for the patient, but then what resources are also available for the family members?
Yeah, well, that's our job too.
Yeah.
Our job also is we joke about the daughter from California. When I was in California, we joked about the daughter from New York. It's usually the person who has not been present. They haven't been the local caregivers. There is a little guilt there. They haven't marched along the trail of hope the same way the rest of the family has. And Reverend Gloria White Hammond gave a wonderful talk that I have on my website about miracles and about hope and how hope changes and how you just need to support the person who's, if it's a religious person, in their faith and what God means for them. But for family members like that, what we usually try to find out is, what are you hoping for the next treatment would do? Because we know that there's grief underneath it. That the reason that there is that they can't imagine their life without this person. And so we explore the idea of, what are you hoping for? One more treatment, that she'll be cured. And what else? Well, that she'll live till the graduation next June. And what else? That she won't suffer. I mean, we keep trying to say, help us understand what you hope that treatment will do. And then we often will find something that it could do, like, yeah, it could make her more comfortable. But sometimes we have to say, I wish it would do that. I worry that it won't. I worry that it won't. I worry that it might even shorten her life. And we have family meetings with families and the oncologist to be able to share those things. And we'll say, and you'll still have your oncologist, even if you're not on treatment. And everybody's surprised by that, including, and the oncologist is incredulous. Says, of course, you never would get out of my care. Of course, I'll care for you but people think they have to pay with their taking treatment. Otherwise, they'll lose that whole oncology team that they've been with for years and years and years. And so in a family meeting, I'll often make it clear that, Dr. So-and-so is your doctor forever. He's just worried that this treatment will actually shorten your life or make it worse. He can't do that to you.
And it goes back to your quality of life too, right? So like, I talk to people who are like, I can't do it anymore. I am tired of feeling this way and it's my choice to end treatment. And so
And again, we will try to just work with the grief of the family. It's almost always the grief that's making them say that, and the fact that they don't have support in that grief and their love for this person, and often an unrealistic expectation of what good the treatment is doing. And as you said, if they say to the doctor, you can't give up on me, when we're there, we say, she would never give up on you. She just knows that this treatment will make your quality of life so much worse and you won't live any longer. And of course, we clear that with the oncologist before we have the meeting so that we understand, would more treatment help or would it not help? We're always up to date about that. And we try to provide support to the grieving family member, or if they're angry, we're used to
oh,
anger.
absolutely.
We're
Mhm.
used to anger too. And we don't take it personally. We simply, I don't know, invincible niceness kind of, or just breathe in their pain and breathe out compassion. That tends to be our practice. And that's how we support the oncologist too, because it's awful to be the oncologist in that situation. You feel so helpless, and so the countertransference is profound. You feel helpless and hopeless and that you've betrayed this family. And you haven't. You've just been a good doctor. So we help the oncologists and the oncology team, not just the oncology clinicians. We try to help them too.
Two more questions I would love to dig into. The first being, we touched a little bit about like the importance of language, right? So moving away from like palliative care, end of life care to supportive care. Can we talk a little bit about how language impacts based on like cultural diversity, right? So like even in my family, like we didn't talk about, and we still don't really talk about death. We barely talk about, and I'm white middle class, like, a woman, but like it's so interesting. Like when my relatives were ill, like we just knew like, oh, Aunt so and so is just not feeling well. She needed to sleep more. Or so and so can't make it to your birthday party because they're feeling under the weather. And it wasn't actually until like in my 30s with my cancer diagnosis that all of a sudden I got all of this family history out of the woodwork of all of the ailments that everyone had because we just didn't talk about it as a family. And I don't know if it was like, I don't want to project. I don't know if it was like shame or embarrassment or it was just like something we didn't talk about. And I know it being very difficult even for some members of my family when I went public with my diagnosis, like all over social media about, breast cancer, not just any cancer, but like now like female breast cancer. And I'm talking about it like wild. And so how does that play into like the work that you're doing, perhaps with like different cultures and like their acceptance of like a diagnosis? I know we talked a little bit about spirituality and communication, but do you have any like anecdotal like scenarios of that?
Oh, definitely. We are very lucky to have in-person interpreters at Brigham and Women's and at Dana-Farber. And because the interpreters are the ones that actually say the words that the patient and family understands, a social work colleague and I initiated, gosh, many years ago now, 8 years ago now, a series of dialogues with them from all these different cultures. So we could learn what's acceptable in their culture, and they could learn different ways of partnering with the oncologist or with the palliative care doctor in ways that would be tolerable to the people in their culture. And so whenever English is not the chosen language of a patient, we very much want to partner with the interpreter, meet with them ahead of time. And as you said, in some cultures, the main lesson I've learned is that the US has a very direct style of communication. Every other culture in the world, almost, except maybe Russia, but maybe not, has an indirect style. And the way we talk is thought to be very rude in many, many cultures. And so, what you need to do, and maybe in your family it's the same thing, what you need to do is say, there are patients who have X happen to them, and they are worried about why. And then see, has that ever occurred to anybody in your family? Or you need an interpreter and a social worker often to be able to explore. Sometimes the patients will tell you that it's very rude to talk about death, or talking about death is like wishing death on a person. So then what you mostly need to get across is that you're worried about functional aspects, that time might be shorter than we hoped, is a way of putting it. And if things need to be done in the family, this might be a good time to start doing them. Somebody needs to be seen if a will needs to be done. If there are big decisions that need to happen, we hope that your treatment will be incredibly successful. We worry that there might be some complications or issues around it. Can you help us know what your family needs to do? And if they say you can't tell her because we just don't do that, then we go in and we say, would it be okay if we asked her in front of you if she wants to know? In many cultures, they'll say, no, my son is the one who, or they're, familia, like in Hispanic culture. No, the family makes these decisions. I don't make these decisions. Well, then there's no ethical problem. You say, so would you like us to talk to the family? And then the family will talk to you? Absolutely. They know what I need to know. So it's really respect for the different cultural tradition. It's training, curiosity. There's no really such thing as cultural competence. We call it cultural curiosity because it really is curiosity. And as you said, among US white, whatever mainstreams, there's so many different ways. And there's so many different thoughts about it. So we tread very lightly. If there are big decisions that have to be made, we push a little harder, and we share our worries that if, for example, a patient with very advanced cancer who's not really awake too much were to be resuscitated when they died, we try to make it clear that would really be hurtful. And to protect the patient, they would never be back to even as good as they are now. So we try to find who in the family we can explain that to, because why would they know? They don't know. They've seen only the miracles. So when it's really serious, we do our best to figure out who's the right decision maker for the family, how many of the family members need to be there, how we can share in a very indirect and ideally culturally sensitive way our concern, our worry, our fear, and that we need to protect the patient. And there are lots of ways that we can do that.
Gosh, I have so much to learn. I'm like going to start looking into like these cultural trainings and curiosity. I'm very curious. And, we've been fortunate at survivingbreastcancer.org. A couple of years ago, we received a grant to offer our programs and services in Spanish. And then we brought on two Hispanic breast cancer survivors and thrivers to help lead those programs. And it has just been like eye-opening and such a great resource, because now we have people like who've gone through breast cancer, but also speak the native language and some of the cultural differences. And so that's been wonderful. But it's not something you learn overnight. And it's so important for us to kind of get out of our like ethnocentric ideas of, the US mindset and the directness. And, we hear all the time too, it's like, okay, I want to be in the doctor's office. Don't sugarcoat it for me. Just tell me how it is. And then to have this other extreme of like, I need compassion and empathy, and knowing that we don't really talk about, we won't say like the D death word, because we don't want that to be manifested into my reality and different things like that. So I really appreciate you bringing up those cultural differences and
They're
sensitivities.
very important, and they're so empowering, and it's so respectful to patients and families as you explore gently with them. We do have some resources on the website and a few resources in our book about this topic,
Okay,
which you
great.
might find useful in your
Yes,
group.
remind me the name of your book. I'll definitely link to it as part of the podcast.
It's Comprehensive Guide to Supportive and Palliative Care for Patients with Cancer. The website has sort of more digestible things. And there's, as I said, a wonderful talk about miracles from Dr. Gloria White-Hammond.
Yeah, and I think understanding that culture piece too builds a lot of trust between you and the patient and their families, knowing that you've developed like this awareness of how they like to receive their information as well. So that's so important.
And we tend to ask everybody, how do you like to get your information? Do you want all the details? Do you want the big picture? We try to explore what's the best way to talk to anybody about
Mm-hmm.
serious things, because
Absolutely.
everybody is so different and you can't guess.
Yeah.
At some level, there is a big difference between engineers, and novelists, but
So my last question for you, Dr. Abrahm, is, we're talking about such a heavy topic, and I admire all of the work that you're doing, what you were able to spearhead with your practice and your expertise in this. But what would you recommend to other people in your field, and even for yourself, in terms of self-care and going on after you receive all of this heavy information from your patients, that keeps you going day in and day out without getting burnt out?
self-care is key. Oncologists have a huge rate of burnout. I
Yes.
think for me, it's because they have unresolved grief that nobody allows them to talk through. And luckily, in palliative care, we have a remembrance of the people who we lost every week.
Oh, wow.
We
Wow.
talk
That's
every
beautiful.
week about, we don't talk about everyone, but someone will do a poem or piece of music or something that's evocative, and then we read the names of the people that we know passed, and whoever wants to can talk about them. And then just being aware of your own vulnerabilities, who makes you sad, how do you feel when you come out of the room? You didn't feel that way before. How come you feel that way now?
Mm-hmm.
Each person, I do exercise. People do exercise. I think exercise is very helpful. I need to escape into a novel at lunchtime every day. I have the Kindle app on my phone, and I have to read for 15 minutes. I have to get away somewhere else. And that helps me a lot. if I need to, and if I've had a very tough conversation, the nurses will often get me a cup of tea, and I might, if the weather's good, take a walk around the block just to let myself feel all the feelings. You have to be very mindful and care about that. I've trained in mindfulness. I've trained in hypnosis. But reading to me gets me away, or going to a museum. Everybody's different. So you need to find the things that fill you back up. I think writing makes me feel good. I feel like I'm putting things together that are important to me in a way that I can share with others. You're absolutely right, though. The work is so meaningful, though. As you said, that I was talking with someone this week who is a mindfulness practitioner, and she's in the hospital, and she just glows. We were talking about healing. Talking to her about healing, even though she got bad news about a test, and we needed to do some serious conversations, and I was tearing up, and so was she. She was more than I, because I've been taught not to let the patient take care of me. But you leave a room like that and you're just full of wonder and gratitude. Yes, you're sad, and
Exactly. Thank you for sharing what fills your cup, and, for patients and medical professionals and doctors that listen to our podcast as well. I know these will be really good and healthy tips.
Thank you for sharing your website, and I will certainly share its resources with whoever comes to my website.
Absolutely. Well, Dr. Abrahm, thank you so much for spending the time with us. I'm excited to get this information out to our community. And for all of you listening, please feel free to shoot us an email if you have any questions, if you liked this podcast episode, and we will be in touch until next time. Thank you. And thank you, everyone, for listening to our show. I would like to acknowledge that all of the information on our podcast is from personal experiences and is not a substitute for professional medical advice. You should always contact your medical care team. If you are looking for specific topics or would like to be a guest on our show, please feel free to reach out. My email is laura@survivingbreastcancer.org. Our show is made possible by our nonprofit, survivingbreastcancer.org, and by our incredible donors like yourself. You can hop on over to survivingbreastcancer.org to sign up for our mailing list, make a donation, and explore the 400+ programs we offer each year at survivingbreastcancer.org/events. Until next time, keep on thriving.